Hello, everybody. Welcome to another episode of Stories from the Edge of Life. We have another inspiring guest today, Dr. Tanvir Alam. Dr. Alam, would you mind introducing yourself to our audience?
First, let me thank my good friend and colleague Dr. Parag Bharadwaj, MD, for inviting me to this forum. My name is Tanvir Alam. I am a GP here in UK. I used to be an orthopedic surgeon and any consultant by background, but I've been doing general practice for some time. And I believe the focus of our talk today is going to be on palliative care in the community and the community focus on this highly complex and rewarding field of medicine. Thank you.
Great, thank you. So, just for the sake of the audience, I have known Dr. Alam since my medical school days, and we've been good friends. And life has a strange way of uh, things working out. I'm a palliative care physician in the US, and he is, like he mentioned, a GP in the UK, but has a very special interest in palliative care. So that's a confluence of interest professionally. Now, Dr. Alam, would you mind sharing with us uh, a typical palliative care visit that you make? There have been times when I've connected with you over a call, and because of the time difference, it's probably around midnight, past midnight, and you're making a home visit to a patient to address a crisis. So, what's a typical situation that draws you to see a patient in the middle of the night, and how does it all work out?
Right. So there are two aspects of this. There is daytime palliative care, which is done at the surgeries, which are the places where general practice is conducted in the UK. And then there is palliative care, which is done in unscheduled care, which is after 6:30 in the evening until sort of 8 in the morning when the day service resumes. So those patients who become acutely unwell in terms of end of life symptoms in the daytime, well, they will be seen by their respective surgeries in the daytime. But then, due to workload pressures and the way things are, sometimes these things can, they go onto a telephone list. And if the telephone comes in quite late, say about 5 or 5:30 in the evening, and there is no possibility for the surgery to address that, so then it comes on to the unscheduled care. When the call comes onto the unscheduled care pathway through the 111 system, the call is then logged. It comes on to our system, where we then have to make contact with the next of kin, who will inform us, what kind of symptoms are going on, and we would have a summary care record, but not all the exhaustive records. So it's sort of you're going in blind to a certain extent. So you have to gauge the situation, what are the end of life symptoms, and then give it the earliest possible response or disposition, which is a home visit within 1 to 2 hours. That's considered to be the most urgent visit that we do. And the typical kind of reasons why we do those visits will be the end of life symptoms like pain, agitation, sickness, and secretions in a patient who is now less responsive and unable to swallow anything by mouth. So these are typical end of life symptoms, and we react to that. And that is why sometimes these visits, and many times these visits happen in the dead of night, because uh, the the drug chart has not been done, or the anticipated medication prescription was not ready, or the symptom presentation was very late in the working day, so it falls over to unscheduled care.
Got it. So, two questions. Number one, is palliative care synonymous with end of life care in the UK?
Palliative care used to be clubbed into that category, but now they have taken on a larger number of conditions. There is a gold standards framework which is in place, where the patients are graded according to um, green, amber, and red category based on the severity of their condition and their prognosis. So this is maintained by the local palliative care team for a particular area. They liaise with the various surgeries and the hospital staff via a multidisciplinary team meeting to constantly update this. So now it is no longer just cancer. We have patients who have very severe COPD or end stage heart failure, a wide variety of conditions, including those complex pediatric patients who are obviously under the children's hospice as well. So, so it has now grown in breadth and scope. And the GSF has helped us, the gold standards framework, to identify those that should be closely monitored because their symptoms are going to progress rather quickly, and those that for whom a phone call just to make sure that they are, sort of stable at this point, or what other kind of assistance would be necessary from us. So three categories: green, amber, and red.
Got it. And so the other question I have for you is, typically when in a lot of different countries, the typical mindset is when somebody is that sick, you take them to the hospital. And what you're describing is, in the end of life care scenarios that you get involved with, patients are actually cared for at home.
Yes.
Could you elaborate a little bit more about, why patients are given that option or they choose to be at home, and how does that work out?
So when a patient is referred into the palliative care system, either by whichever primary referring team, whether it's respiratory or cardiac, once they go on to the palliative care system, then they go on to this gold standards framework, like I mentioned. So at that point, a conversation is made either in the hospital setting, where the palliative care nurse and the consultant will have this conversation with the patient because they are not for active treatment anymore, or it will come back to the surgery. And there is something called as a My Care Choices record, an MCCR. Now, the My Care Choice record will, the patient will be asked explicitly whether they would want to be treated at home, whether they would want to be resuscitated in the case of a cardiopulmonary arrest. So at that point, this record will reflect their dying wishes, whether they wish to be treated in a hospice or at home, and the DNA CPR form and the respect form, which is a sort of um, a more elaborate version of the do not attempt resuscitation form, will also be completed. So that completes all the documentation. Therefore, now even if an ambulance call out is made for this patient is not for CPR and is therefore and has a respect form, therefore will be kept at home. So symptom palliation can still happen via paramedic service, but because of the records which are maintained and the My Care Choice record, uh, the patient opts to stay at home. If the patient has got terminal dementia and cannot give consent, then the next of kin who have the power of attorney for health will then sign the appropriate DNA CPR form and respect form on the patient's behalf.
Got it. So that's a choice that patients and their families, if the patients are not able to speak for themselves or choose not to speak for themselves, can make. And that is not to
Yes.
pursue these very aggressive interventions. Because, in our days when we were training, um, we just felt that we had to keep treating, right?
Yes.
Uh, and those conversations hardly occurred with the patients and their families. So I'm glad to hear that, you know, patients are involved in those conversations and are able to make those choices. So you've seen a lot of patients in your palliative care experience. Uh, would you care sharing some of your insights in terms of what you've learned about, like one of our previous speakers mentioned, the human condition and how patients and their families are able to deal with those adversities?
I think there are two aspects to this. One is the medical side of it from the doctor's perspective, and the second is the patient's perspective of this. So as doctors, we always want to treat everything, and certainly reversing a condition gives no greater satisfaction to a clinician. However, in palliative care, this poses a unique challenge because you cannot reverse the condition. You are only doing symptom palliation. So, a very important part is the is the mindset of the clinician that he is here now to do symptom palliation. From the patient's perspective, of course, the experiences are varied. Some of the things which I have taken from patient conversations are, um, "Doc, can I have a few more days? Can you give me some more time?" And that seems to be a recurrent theme for a lot of patients. Obviously, I'm not generalizing with all. And the emotional aspect of facing death and the certainty of death, which is just around the corner, it hits people at the very end of life. Um, in a vast majority of situations, they then have regrets about how they have managed their affairs or their interactions with their family or next of kin. So there are very many emotional aspects to palliative care, and it is a deeply um, complex conversation and a deeply complex consultation, because you are not just looking at the patient here and their symptoms, but you're looking at their support network, their next of kin, how they are coping with the adversities of seeing their loved ones now slowly drifting away in front of their eyes. And that is an often neglected part of palliative care, is actually the care of the carers, because the carers are there at the end of life, but who is there to care for them? So they end up being the voiceless in this conversation. An example of this I'd like to illustrate. I did a home visit once on a 29-year-old lady with stage 4 ovarian cancer, and she had 5 children, and the youngest of which was about 9 months old. And her mother was there, and the grief and the anguish on her mother's face has never left me. The exact word she said is, "I was hoping that she would outlive me and she would be there for my funeral, not the other way around." And there was the husband who was stroking her hand as she was drifting away with the anticipatory medications that I had administered. um, and the children were at a different location, being looked after by members of the extended family. And it was very difficult to be in that room. It was very difficult to maintain an objectivity about it, because at the end of the day we are all human, and the enormity of the loss hits you many times. So palliative care consultations, I find, are very complex, multi-layered, and filled with great emotional depth and content. I think those are some of the challenges which uh, I have observed and faced, even when we have registrars who are training with us. Uh, they find it also to be, these kind of consultations to be the most complex and multi-layered and multifaceted, with so many different things which need to be addressed, not just the symptom of the patient.
Thank you for sharing that. Now, you did mention that often patients ask you for more time. And I don't know if it was just the patients or also their family members, but I'm curious to hear from you if they ever share with you or you ask them, like, what is that they want to do with the extra time that they're requesting for? Do you get, do you have a theme?
Yes, if I know somebody has got some more time, my first question to my patients, which may sound strange, is, have you made your bucket list? If there is enough time, then I do ask that question, because many times people don't actually think about this until it's really late. And I also ask the family members when it is at the absolute end of life, have you called everybody who needs to be called? Because that's another regret which people have afterwards. Oh, I didn't call my aunt, or I didn't call my cousin. I should have called them. They needed to know that this individual was drifting. Um, and the greatest regrets tend to be from an emotional perspective. Well, sometimes People have burned the bridges with their families, and at the end of life, they want to reconnect with them. But alas, it is too late to make that change at the very end of life. But it's a good conversation to have when you know that they are perhaps potentially in the red category or the amber category, and what their plans are. But the recurring theme is the inability to connect with their loved ones because of whatever differences they've had over the years, and the desire to meet them once more, to talk to them once more, to apologize, to say sorry, and to go in peace. And that seems to be the recurring theme of what I have observed. Is the number one reason why people ask for more time.
Right. So it's not the materialistic things that one seeks in that time frame, like
No,
going to a particular place or so forth. It's making those connections with the
absolutely.
people who brought meaning to their lives. Right.
Yeah.
All right. Well, thank you for sharing your wisdom. Any parting notes in terms of or comments about any other pearls that you have picked during your professional career?
Well, I think palliative care is a rapidly growing segment of medicine because we have now the necessary medical interventions to give treatments for as long as possible. So people come into palliative care and stay there for a long time. It's not like how it used to be. Previously, it was just okay. This is the end of life pathway. We need to prescribe diamorphine, midazolam, hyoscine, and nosinine, and that's it. It's not like that. Now it's become a multi-layered conversation. It's a multidisciplinary team approach. There are community matrons involved in it. There is a palliative care team. There is hospice at home, the GP, the urgent out of hours setup. So we have come a long way. So the growth of palliative care has been a positive development for patients, and we should continue to spread that message and to drive home the point that palliative care is not just about somebody dying at the end of life. It is the process of that transition through the terminal phase up to the end of life. And palliative care deals with those patients during that entire process. It is not just localized to the end of life.
Right. And you know, if you move palliative care upstream enough, you detach it from the prognosis uh, prognostication completely. So we'll have a few more talks about that coming up in a few uh, episodes. And well, I do thank you for sharing your wisdom with us, and thanks for what you do for the patients.
Yeah, thank you, Dr. Parag, and thank you for the fantastic work you're doing through Palliative Care Network. It's the message and the knowledge which has been imparted by yourself and your team over the last several years is nothing short of the greatest charity that one can do. That is the charity of imparting knowledge, which is an act which grows in perpetuity. So that is knowledge multiplies the more you divide it. As individuals like yourself who are a testament to the dedication and passion to do that. So I commend you and your team for your stellar efforts in this cause.
Well, you're very kind, sir, and thank you for all your support over the years. And we look forward to having you participate in future conversations as well.
Thank you.
All right, take care.
Bye bye.
Did you like this story? If so, please subscribe to this channel and like and share the video. Want more? Buy the book, Stories from the Edge of Life, available now on Amazon for more stories like this. All proceeds support Palliative Care Network, a nonprofit dedicated to alleviating suffering and improving the quality of life for patients facing end-of-life issues. Consider extending your contribution by donating through the link below. Thank you for your support.